Hello and welcome to this geriatric podcast on part 2 of cognitive impairment. My name is Mohammed Farik Jabir. In this podcast we'll be discussing about the cognitive assessment needed for diagnosis of dementia, the investigations and the management. Clinical cognitive assessment is primarily used to involves history taking, preferably a collateral history from a carer, cognitive and mental state examination, physical examination, and review of medications to identify any drugs impairing cognitive function. Clinical cognitive assessment should assess the following domains of attention and concentration, orientation, language, memory, and executive function. In the hospital setting, formal cognitive testing can be utilized by using tools such as the mini mental state examination. If you're placed in a GP setting, GPs have access to the general practitioner assessment of cognition. Going on to investigations. Investigations of suspected dementia should include conducting a basic dementia screen at the time of presentation, usually in primary care, including routine hematology, including electrolytes, calcium, glucose, U's and E's, LFTs, TFTs, B12 and folate. Perform a midstream urine test if delirium is a possibility. Imaging involves structural imaging to exclude other cerebral pathologies and helps to establish the subtype as well. MRI is used to assist with detecting subcortical vascular changes. However, CT scanning could be used as well. Management involves using drugs such as acetylcholinesterase inhibitors, donepezil, galantamine, and rivastigmine. These are primarily used for moderate Alzheimer's disease, where that is MMSE score of 10 to 20 points. Memantine should be considered for patients intolerant of acetylcholinesterase inhibitors or suffering severe Alzheimer's disease. The focus with regards to the carers should be the emphasis on promoting independence and maintaining function. Health and social care staff should aim to promote and maintain the independence, including mobility of people with dementia. Care plans should address activities of daily living that maximize independent activity, hence function, adaptation and development of skills, and minimize need for support. They should also address the varying needs of people with different types of dementia. Indications that suggest that a person with dementia is no longer able to live in the community are when they require more supervision than the caregiver can provide. There is caregiver burnout or depression. There are issues at home with regards to safety, behavioral issues such as an increase in delusions, hallucinations, finding the patient wandering more at night, and loss of bowel or bladder control. At this point, the carer would have exhausted all resources available in the community setting, such as district nurses, and would opt either for placement or social worker input. That's about it for this podcast. Thank you for listening and goodbye.